Hi guys, in this section we are going to talk about the GT12. So all the questions which were asked in your NEET GT12 from the section of general surgery. So let's start by talking about it. Now, the first question which you have in front of you is, the swelling shown characteristically moves with swallowing only, respiration, tongue protrusion, or carotid pulsation. Okay, so this is one of the very important topics for you as far as the thyroid and the benign conditions of a thyroid are concerned. First of all, let's try to understand what is this. So here you have a midline swelling. Okay, so you have a midline swelling, and what is the relevance of this? This is a CT scan. Okay, so this is a CT scan. Are you able to appreciate that this is a hyoid bone? Hyoid bone, and the swelling is basically present just below this hyoid bone. So what I'm talking about? I'm talking about thyroglossal duct cyst. Okay, now what the question is asking, that the swelling characteristically moves with. It does move with this swelling, that's okay, but there's nothing characteristic about it, because even the thyroid swellings are going to move with the swelling. So the characteristic feature is that it moves with the tongue protrusion. Okay, so that is the characteristic feature about a thyroglossal duct cyst. Okay, so let's quickly revise about the thyroglossal duct. Thyroglossal duct cyst. Let's kind of quickly revise about this. So what you need to appreciate over here is that you have this particular tongue. Okay, and what happens is, from this particular base of the tongue, what arises is your thyroglossal duct. Now this thyroglossal duct, it basically goes around the hyoid bone and it reaches the neck and leads to the formation of a thyroglossal, and it leads to the development of a thyroid gland. Now after this kind of embryological development of a thyroid is done, this thyroglossal duct should disappear. Okay, but if at all this thyroglossal duct does not disappear, if it kind of persists, in that particular scenario, it can lead to the thyroglossal duct cyst. Okay, it can lead to the thyroglossal duct cyst. And the characteristic feature about this thyroglossal duct is, or duct cyst is, that it most commonly is present just below the hyoid bone. So a very important MCQ over here is, what is the most common location? The most common location of this thyroglossal duct cyst is subhyoid, and mind you, this is going to develop if at all this thyroglossal duct, it fails to disappear. Normally it disappears, but if it fails to disappear, then it will going to lead to a thyroglossal duct cyst. Thyroglossal duct cyst. Okay, now the characteristic thing about this particular thyroglossal duct cyst, that it's going to move with deglutination as well as with the protrusion of the tongue, because this thyroglossal duct is attached to the tongue, and if at all you protrude the tongue, what's going to happen? The duct is kind of going to move, and because of that the cyst is going to move. Okay, I hope you have understood this particular point. That's the relevance of this. Okay, right. So what is the management of this? The management is excision. Okay, because if you just let it be there, there is an increased risk of infection. It's just a subcutaneous thing, as you can see over here. It is just below this particular skin, right? So it is just subcutaneous. So if at all you just leave it over there, what's going to happen? It may get infected. And that is the reason why, if at all you have this thyroglossal duct cyst, you have to kind of excise this. That's what you kind of do the management of this. Okay, so you have to kind of excise that. Perfect. Right. Now, the instrument kind of is best used for what? So, first of all, you need to appreciate what is this. This is what is a Babcock's forceps. Okay, what is this? This is what is your Babcock's forceps. Okay, so able to appreciate this particular hollow thing below this. So this is basically used to hold or catch hold of any hollow structure. Okay, so any particular hollow structure can be caught with this. Now, out of the options, which is the hollow structure, like hollow visceral structure, it is the intestine. Okay, so the instrument shown is best used for holding the intestine. Okay, I hope you're able to appreciate this. So blood vessels can know, it's basically best used for holding your intestine. I hope you're able to understand. It's not an ATLS forceps, it is a Babcock's forceps, so it is used for holding the intestine. That's what you need to understand. Okay. Now, a patient comes with a gunshot injury to the face with an expanding hematoma and a stridor. Okay. What should be the immediate next step? Okay. So, what you need to understand is, now this is basically trying to test the basics of your ATLS. In the ATLS, first is you need to control the external hemorrhage. So this is what okay. So what are the sequence of events which you basically follow in the ATLS? It is called as a small c, A, B, C, D. What is this small c standing for? So the small c is basically for control of external hemorrhage. Okay, so is there any external hemorrhage happening over here? No, right? I mean, there is a whatever the bleeding that is inside, below the skin, and that's the reason why it is able to compress on the trachea and the respiratory kind of system, ultimately leading to the respiratory distress. Okay, now, just after this, what you have to do is you have to check for airway with cervical spine. Okay, so cervical spine you have to kind of evaluate and you look for the airway. So here the patient is having stridor. Stridor is basically screaming and telling you that, you know what, I have respiratory difficulty. Okay, so stridor is basically trying to tell you that, you know what, I have a respiratory difficulty, and if at all this is a thing, then in this particular scenario, what you have to do is a cricothyroidotomy. Okay, so whenever the patient is in the respiratory distress, so if at all the patient is in the respiratory distress, in this particular scenario, the immediate or an emergency intervention, not an immediate, rather an emergency intervention. So what is an emergency intervention? Emergency intervention is your cricothyroidotomy. Okay, if at all you talk about the definitive, in this particular scenario, it would be kind of a surgical exploration, control of the hemorrhage, all those stuff. But the emergency intervention is cricothyroidotomy, and if at all, let's say there is a delayed or there is some other reason for which the respiratory distress is there, in that case, you can go ahead with the tracheostomy. So here, let's not talk about the definitive, but here, because the patient is in the respiratory distress, the next thing which you have to do is cricothyroidotomy. Okay, are you understanding? You have to establish the airway, and once the airway is established, now you can maybe shift the patient to the operating room, do the kind of surgical wound can be opened up, and whatever the hemorrhage is there, that can be kind of controlled. Okay, so I hope you are able to appreciate this particular stuff. Now, let's kind of talk about others as well. So B is basically for the breathing. C is basically for the circulation, and D is for your disability. Okay, that's fine. So these are the sequence of events which you basically follow in the ATLS. Small c, A, B, C, D. Small c is for the control of an external hemorrhage. Okay, a 55-year-old male presents with a slow growing swelling in the parotid region. FNAC basically shows that it's a pleomorphic adenoma. What is the correct treatment for the same? So in other words, they are basically trying to ask you, what is the treatment of choice for pleomorphic adenoma? Total parotidectomy with facial nerve sacrifice? Never. That is done only if at all there is a malignant transformation. If at all the facial nerve is involved, in that particular scenario, yes, you may go ahead with the total kind of parotidectomy with the facial nerve sacrifice, but not otherwise. Okay, so usually it's not the one which is kind of done. Local excision? No. Okay, co-needle biopsy and observe. Why would you observe? It's a superficial parotidectomy. Okay, so if at all there is a pleomorphic adenoma, the treatment of choice is superficial parotidectomy. So what you need to understand in the treatment of a pleomorphic adenoma is three things. Pleomorphic adenoma. First thing what you need to understand and appreciate over here is that it is the most common tumor which arising from the parotid gland. First thing. Okay. Second thing what you need to understand is that what about enucleation? Enucleation is never done. Okay, it is never done. Why it is never done? because it can lead to recurrence is called. So what you need to understand with the pleomorphic adenoma is that it has something which is called as a pseudopodia. What is pseudopodia? These are like the, what do you call as the extensions of this particular tumor from that particular capsule outside. So these are what is called as a pseudopodia. That is a false limbs, okay, of this particular tumor. So if you just try to go for the enucleation, what is going to happen? Multiple residual tumors will be left behind and there will be multicentric and multifocal recurrence. Okay, so in this particular scenario, there's going to be the multicentric and the multifocal recurrence after enucleation. So it is never done for pleomorphic adenoma. Most of the times, what you basically do is superficial parotidectomy. This is what you would say is the treatment of choice. What is the treatment of choice? Superficial parotidectomy. That is what is the treatment of choice. But if at all, the question says that there is involvement of the deep lobe as well, because most of the times the pleomorphic adenoma only involves the superficial lobe, which is the majority part of the parotid gland. But if at all, total parotidectomy, this is basically done if at all the deep lobe is involved. Now, how would you know whether the deep lobe is involved or not? So when you do the kind of a laryngoscopy or something, what can happen is that the uvula can be shifted towards the opposite side. Okay, are you understanding? So that is if at all they say that the uvula has been shifted towards the opposite side or the tonsils have been shifted to the opposite side or something. So that basically tells you that the deep lobe is also involved. Okay, so that is on the intraoral examination. If at all they give you some things like that, then in that case you have to remove the total parotid gland. But again, you will not kind of remove the facial nerve. That will only be removed if at all there is a malignant transformation and the involvement of the facial nerve is also there. But most of the time what you basically do is a superficial parotidectomy. I hope you have understood this point. Now, which organism is most commonly responsible for the surgical site infection? It is a Staphylococcus aureus. Okay, it is a fact which you need to remember. Staphylococcus is the most common organism which is responsible for the surgical site infection. Okay, right. Okay, which IV fluid is most suitable for initial resuscitation in the hypovolumic shock? Okay, so the answer over here is the Ringer's lactate. Okay, so whenever you have a patient with a hypovolumic shock, the first treatment for that is Ringer's lactate, RL. Okay, so most of the patients of the trauma or like dehydration, whenever they come, we start the patients on crystalloid. And what is the crystalloid which we are starting them on? It's a Ringer's lactate. That's what you basically usually do. If at all the patient is a small child, okay, small children, then you may start with the dextrose normal saline or something. But if at all nothing is mentioned, the first fluid to be started is the Ringer's lactate. Okay. Which lymph node level is most commonly involved in the oral cavity carcinoma? Okay, so in the oral cancers, which lymph node station is most commonly involved? The answer over here is 1. So oral cavity cancers, they usually involve the submental and the submandibular lymph nodes. Okay, most commonly, these are the lymph nodes which are involved. That is the lymph node level 1. Okay, submental or the submandibular lymph node 1A or 1B, these are the ones which are most commonly involved. So these are the few lymph node involvements which you should be aware of. So for the oral cavity cancers, which basically includes the lip, the floor of mouth, the buccal mucosa, on those particular stuff, most of the part of the tongue, what is basically involved is the level 1. Level 1. Okay, oral cavity cancers, especially the lip, the floor of mouth, or the buccal mucosa, most common lymph node involvement is the level 1, followed by the level 2 and 3 can also be involved. But if at all there's most commonly what is involved is the level 1. But if at all you deal with the oropharynx, in which there is tonsils or the base of the tongue, that is the posterior part of the tongue. In these particular scenarios, the most common lymph node involved is the level 2. Then level 3 and 4 can also be involved, but the level 2, that is upper kind of sternocleidomastoid kind of lymph node, is something which is involved. Upper, middle, and lower jugular. So upper jugular lymph nodes, those are the ones which are involved in the oropharynx, that is your tonsils, and the base of the tongue, that is the posterior part of the tongue. And then for the nasopharynx, the lymph node involvement most commonly is the lymph node station 5, which is involvement of the posterior triangle. Okay. So for the nasopharynx, it is lymph nodes level 5. For oropharynx, it is level 2. And for oral cavity, that is space of like the lip or the floor of the mouth or the buccal mucosa, then it is level 1. Okay. So these are the things which you need to understand and remember, important. Now, out of all the oral cavity malignancies, the one which has the maximum risk of the lymph node involvement is the tongue. Tongue has the maximum risk of lymph node involvement, and the lip has the least risk of lymph node involvement. So lip and the hard palate, these are the ones which have the least risk of the lymph nodal involvement. Okay, so these are the things which you need to remember. Now, which graft contains epidermis and the part of the dermis? So what you need to understand is that first thing is the graft and the flap. So what is the difference? The graft, they do not carry their own blood supply, and the flap, they carry its own blood supply. Now the graft can be either partial thickness or they can be full thickness. So what about the partial thickness grafts? Partial thickness grafts are the ones which I would say is having epidermis plus part of. Okay, so the partial thickness grafts are the ones which are having the epidermis and the part of the dermis. So here answer is the partial thickness or a split thickness graft. Okay, partial is also called as a split thickness grafts. Okay, the partial thickness or the split thickness grafts are the ones which are having epidermis and the part of the dermis. On the other hand, the full thickness grafts, these are the ones which are having epidermis plus the dermis. So epidermis and the entire dermis, these are the ones which are basically present in the full thickness graft. Okay, so I hope you're able to appreciate the difference between the partial thickness and the full thickness graft. Partial thickness, epidermis plus the part of dermis. Full thickness graft is the epidermis plus the entire dermis. Okay, so yeah, the question was asking epidermis and the part of the dermis, that is a partial thickness or the split thickness graft. A patient presents with the dilated tortuous veins in the leg, edema and the pigmentation around the ankle. Which complication is most likely? Okay, so what you need to understand, what are they describing? Okay, so they are basically describing you the varicose vein. Varicose vein. So what is the definition of a varicose vein? A vein which is dilated plus tortuous plus elongated. Okay, so dilated, tortuous, and elongated veins, these are the ones which basically define as a varicose vein. Understood? Now, along with this, there is an edema and there is a pigmentation as well. So this is basically trying to tell you that there is a like advanced kind of a varicose vein. So in such scenarios, what can happen is obviously arteriolysis will not happen because of this, right? Neuropathic ulcers are not going to happen. Malignant ulcers are not going to happen. So definitely the answer is venous ulcer. Okay. So yeah, like that's what you need to understand. If at all there is a varicose vein, and if at all it leads to the pigmentation and the skin changes, ultimately the patients are going to land up into venous ulcers. As simple as that. Question was pretty simple, nothing major, but all you need to understand that every dilated vein is not a varicose vein. It has to be tortuous and it has to be elongated as well. And obviously, along with the skin changes like the edema and the hyperpigmentation, it is at a higher risk of suffering from a venous ulcer. Understood? Perfect. Now, according to the ATLS protocol, what is the first priority in the trauma management? So we have talked about this like in this particular session only, that what is the sequence of events as per the ATLS? It is C, A, B, C, D. So what was this C standing for? C. So students get confused and they mark C as the cervical spine. No, this C is not for the cervical spine. This is the control of an external hemorrhage. That is what is the answer. Okay. Not just any hemorrhage, external hemorrhage. Internal hemorrhage you cannot control firsthand. I mean, you don't know that till that time. So assessment of the circulation, no, that's the third. Airway in the cervical spine, okay, that's there, but that's later on. And disability assessment is again the last one, okay. So please understand this C basically stands for control of external hemorrhage. What does this stands for? Control of an external hemorrhage. Very, very important. I hope you have understood this point, okay. Perfect. Now, which salivary gland tumor is most commonly malignant? So out of the options given to you, parotid gland, submandibular, sublingual gland, all are equally malignant. So what is the answer over here? It is a sublingual gland. So what you need to understand in the salivary gland tumors is the basic dictum basically says that the risk of malignancy in salivary gland tumor. Okay, so the risk of malignancy in the salivary gland tumor is inversely proportional to the size of the gland. So what does this mean is that if at all you take all the tumors involving the parotid gland, most of them are going to be benign. Submandibular gland, okay, it can be benign, malignant 50-50, but in the sublingual gland, if at all there is a tumor, it is more likely to be malignant. Are you understanding? So which salivary gland tumor is most commonly malignant? The answer is sublingual gland. Okay, so the basic dictum basically says that the risk of malignancy in the salivary gland tumor is inversely proportional to the size of the gland. Smaller the gland, the more is the risk of malignancy in that particular gland. Okay, that's fine. Now, which flap maintains its original blood supply during the transfer? Okay, so now we are talking about the flap. So flaps, all the flaps, they have their own blood supply. Okay, but the flaps can be free flap. What do you understand by the free flap? For example, this is a flap which I want to take. So let's say if at all I want to take the flap from here, I take this particular flap. Along with that, I take the blood supply as well, and then I put it where it's kind of needed. Okay, along with that blood supply, you cut the vessel. But here you anastomose that particular vessel to another point so that from the day one, the flap or whatever the tissue you have transferred has its own blood supply. Are you understanding? This is what is called as a free flap. So does it maintain its original blood supply? No. It has a vessel which is anastomosed to that particular site, but it doesn't have its original blood supply. So that's not the answer. Random flap is also not the answer. Answer is pedicled flap. So what is a pedicled flap? In the pedicled flap, what you basically do is, let's say if at all this is the vessel which is basically attached to this particular flap. So you are kind of taking this particular flap from here and you're tunneling and you're putting it, let's say, over here. Okay, are you understanding? So the vessel is still attached. You are not cutting this particular vessel. In the free flap, you cut this particular vessel, you take that particular remaining part of the vessel with the flap and you put it at the other location. I hope you're able to appreciate. So what is this? This is a pedicled flap. Which flap maintains its original blood supply? The answer is pedicled flap. Okay. A surgical incision heals with minimal inflammation, no infection, and a good approximation of the wound edges. The type of the healing is called as, it is called as a healing by primary intention. So you need to understand that there are three things, okay? Healing by primary intention. What happens in this healing by primary intention? In the primary intention, what you basically do is that you bring the two edges of the wound together and you take the stitches, okay? So the two edges of the wound are brought together and they are sutured with each other. This is what is called as a healing by primary intention. What do you understand by the healing by secondary intention? So in your life also, many times you would have suffered from some kind of an abrasion or some wound. Every time you don't go and take the stitches, right? So if at all you leave that particular area like that and allow it to heal by granulation tissue, that is what is called as a healing by secondary intention. Okay, that is what is called as a healing by secondary intention. What is the healing by secondary intention? Here, you kind of leave, there is a basically gap which is kind of maintained. You don't bring the two edges together, you don't anastomose them together, you leave some, like, you just leave the wound open. That is what is called the healing by secondary intention. Then there is something which is called healing by tertiary intention. What is this healing by tertiary intention? So in the tertiary intention, this is what is called as a delayed primary repair. Here what you basically do is that you leave the wound open, but you don't leave the wound open for a long time. You leave the wound open for, let's say, 48 hours, and once the infection has kind of gone from this particular wound or it has got under control, now you bring the two edges together like the primary intention, but you're not bringing the edges together immediately. You're waiting for some time. So how it works is that here you keep the wound open for, let's say, 48 hours. Till this time, what you do the dressing, you give the antibiotics, you do all those things. And once the infection has been brought under control, now let's say after 48 to 72 hours, now you bring the two edges together and you take the stitches. So this is what is called as a healing by tertiary intention or a delayed primary repair. Okay, so the difference between the primary intention and the tertiary intention is, in both, the edges of the wound are being brought together, but in the primary intention it is brought immediately. In the tertiary intention or the delayed primary repair, you kind of continue with the what you call as dressing, and you continue with the antibiotics for, let's say, 48 to 72 hours, and after that you bring the two edges together. That is what is called as a delayed primary intention. Understood? Right. I hope you have understood this point. Important. Okay. And the wound quality, okay, or the scar quality is the best. So best scar is what you basically get in the healing by primary intention. If at all you bring the two edges together immediately, the scar quality is the best. Okay. Now, which transfusion reaction presents with fever, chills, but no hemolysis? Okay. So here it is a febrile non-hemolytic transfusion reaction. So here what happens is that there's a patient in whom you have started the blood transfusion. Let's say within 1 to 2 hours or within 1 hour, what will happen is that the patients will develop mild fever. Patients may also have chills, that's fine, but there will be no back pain, no bleeding. All those things will not be there. So if at all the patient has fever with chills, high grade fever with chills, but the patient has severe back pain, the patient had like passing of the blood in the urine, hemoglobin urea is kind of there. So that is what is a hemolytic transfusion reaction. But if at all they just give you that there is a fever with chills, but there's no back pain, no bleeding from the venous side and everything, what they're trying to tell you is the febrile non-hemolytic transfusion reaction. Now this happens because of the leukocytes. These leukocytes, or the WBCs, they release the interleukin, and these interleukins are the ones which are responsible for the development of the fever. So How can you prevent this? This is something which is important. You can prevent this if at all you use something which is called as a leukocyte depleted red blood cell transfusion. Okay, so leukocyte depleted PRBC, okay, packed red blood cell transfusion or something like that. This is how you can prevent the development of a febrile non-hemolytic transfusion reaction. That is what you need to understand and appreciate over here. Okay, acute hemolytic reaction, that is what is going to happen because of the ABO incompatibility. It means that the blood transfusion was kind of mismatched. Like you had to transfuse A blood group, but you, let's say, some reason you transfuse B blood group or AB blood group or something like that. So there was a mistake, a human error that led to the hemolytic transfusion reaction. That's fine. Allergic reaction can happen. That's okay. And the TRALI is a transfusion related acute lung injury. Now, this happens usually not always, but usually when you transfuse, let's say, FFP or platelets. And this is going to take around 6 hours. So 6 hours, like around within 6 hours from the transfusion of the FFP or the platelets. And here predominantly the symptoms will be respiratory. The patient will not be able to breathe. On X-ray, there will be kind of infiltration of the lung, and all you need to do is intubate the patient. Again, this is because of the cytokine storm. So because of the interleukins and the cytokines, the patients are having this. All you need to do is intubate the patient, and once you intubate the patient, after, let's say, whatever time, 3 days, 4 days, the the cytokines and all those things are going to get washed out, and once they get washed out, the patients will kind of recover. Till then, it is your job to give the respiratory support to the patient in the form of oxygen or, let's say, intubation and all those things. Okay, so that is what you need to understand about the TRALI. Okay, so these are the blood transfusion reactions. They are important. Which anesthetic agent increases the intracranial pressure? The answer over here is ketamine. Okay, so the ketamine is the one which is going to increase the intracranial pressure. So the propofol is like having the anti-emetic kind of property. It ensures kind of rapid, kind of clear-headed recovery, and is ideal for the daycare surgery. So I've just put a couple of points which you may remember for all these particular 4 anesthetic agents. Okay, thiopental sodium. It's an it's basically given intravenously, but if at all you give accidentally, it enters into the intra-arterial system, that is going to be very, very catastrophic because it causes intense vasospasm and the crystal formation leading to the gangrene of that particular limb. So you have to be very, very sure when you're giving this particular thiopentol, it should not have any arterial communication. Okay, so that's something which is very, very important. Ketamine, very, very important, what you would call as an anesthetic agent. It causes dissociative anesthesia. So just remember at your level, dissociative anesthesia is associated with ketamine. Okay, then the agent increases the intracranial pressure and the blood pressure. So if at all they ask you that, the patient of trauma, would you prefer ketamine? Yes, because that helps you in increasing the blood pressure. Okay, but at the same time, if they ask you, you want to perform a brain surgery, would you prefer ketamine? No, because it increases the intracranial pressure. Are you understanding my point? So these are the things which you need to remember. Few things which you need to remember about the ketamine. Lastly, etomitate. So in the etomitate, what you need to understand is that it leads to adrenal suppression. This is a very, very important MCQ. So which anesthetic agent can lead to adrenal suppression? It is etomidate. Okay, so agent of choice for the hemodynamic unstable patients, that is a cardiac stable, but causes adrenal suppression. So another thing is for the cardiac surgeries, what you can use etomidate, but the problem with this is it causes adrenal suppression. So this is something which is tested quite a lot. Adrenal suppression, etomidate. Dissociative anesthesia, ketamine. Increase in the intracranial pressure, ketamine. Blood pressure increased, ketamine. Cardiac stable, etomidate. Thiopentol, intense vasospasm, if at all given intra-arterially, so it can lead to gangrene of that particular limb. And propofol for the daycare surgeries. So yeah, this is all about the questions which were asked to you in your GT 12. I hope you gained something out of it. See you in the next one. Bye bye. Take care.